Hey guys, don't mind my crazy hair and my dark circles, but I'm just making this video to show you my project. It's over a below the knee amputation, and I made a PowerPoint, so I'm just going to show you it on my laptop. And here we go. Okay, so below the knee amputation. That's my introduction slide. Sorry. Okay, so what is an amputation? An amputation is the action of surgically cutting off a limb. Now, there are several types of amputations. There are leg, hands, forearm, amputation of digits, elbow disarticulation, partial foot amputation, ankle disarticulation, knee-bearing amputation, above the knee amputation, hip disarticulation, and arm. But for my presentation, I'll be focusing on a below the knee amputation. Okay, so what is a below the knee amputation? A below the knee amputation is a transtibial amputation that involves removing the foot, ankle joint, and distal tibia and fibula with related soft tissue structures. When it comes to the amputation of a leg, there are several ways they can remove the leg according to what the diagnosis is or where the infection stops. A hip disarticulation, which is right here, is a surgical removal of the entire lower limb by transection through the hip joint. A conventional transfemoral amputation, which is above the knee, right there, creates a femur lying in abduction with a large medial soft tissue mass. This deviation from the normal mechanical axis of the limb results from loss of muscle bulk, loss of muscle insertion, and position of the thigh at the time of wound closure. A knee disarticulation, which is right there through the knee, is an amputation done between bone surfaces rather than by cutting through bone. And lastly, a foot amputation, which is at the bottom, is surgery to remove part or all of the foot. Okay, and this is a picture of the anatomy. The top picture just shows the level of the amputation of the lower leg. So this is like the level of where they'll be removing it. And I'll talk about the other line here in a little bit. The bottom picture is showing the cross section of what they are going to be cutting off or through. So you have the tibia and the fibula, and then all of the muscles and vessels surrounding those bones, which I will later talk about when I get to the actual procedure. So this is just like a cross section of where they're going to be cutting through. You got the tibia and the fibula. Okay, so pathology. Sorry if this is like making the screen look weird. Okay, so limb loss can be the result of trauma, malignancy, disease, tumor, infection, or congenital anomaly. Peripheral vascular disease is the most common cause of limb loss overall. Peripheral vascular disease or peripheral artery disease affects the peripheral vascular system, mostly the arteries, and is a manifestation of systematic atherosclerosis and atherothrombotic conditions, which may include stenotic, occlusive, and aneurysmal disease. So the top picture here shows the peripheral vascular system, which consists of the veins and arteries beyond or distal to the chest and abdomen, supplying the arms, hands, legs, and feet. The bottom picture is an illustration that shows how PAD can affect arteries in the legs. Figure A shows a normal artery with normal blood flow. The inset image shows a cross-section of the normal artery. And figure B shows an artery with plaque buildup that's partially blocking blood flow. Okay, so pathology continued. Diabetics who are prone to non-healing ulcers and poor vascularity to the extremities are at risk for an amputation, especially of the foot and leg. Non-ischemic limbs are amputated due to bone or bone marrow tumor, trauma, infection, or congenital defect. The goal of the surgery is to preserve as much of the movement of the proximal leg as possible and to allow the patient to eventually ambulate with a prosthesis. And you can find all this on page 964 in AST. Okay, so for diagnostic testing, I couldn't find a whole lot of the tests that they would perform, but there is history and physical and then standard x-rays. I also found some tests where they measure blood flow through the limb. One is a Xenon 133 study, which uses a radiopharmaceutical to measure blood flow. And another one is oxygen tension measurements, with an oxygen electrode is used to measure oxygen pressure under the skin. Okay, so equipment and instruments. These are just a list of all of the different things you would need. So a power saw, oscillating saw blade, a giggly saw, a Satterley bone saw, the tourniquet, culture tubes, and a hemovac drain. Okay, and these are just pictures that I put up. The top left is the Satterley bone saw. The middle one is the Liston amputation knife. The far right is the oscillating saw. And then at the bottom is the giggly saw handle and the saw. Okay, and this is a Mayo stand setup. I actually got to observe a below-the-knee amputation, and this is an actual picture of what the lady used. It didn't show up very good on my laptop, but in the picture there's a Brunbone curette, a self-retaining wheat lantern, a Lexel rongeur, hemostats, Army Navy, Sin retractor, a number 3 handle with a 10 blade, a Ferris Smith forceps, curved Mayo, scissors, Volkmann Reich retractor, and a Freer elevator, and some laps. So that is that. And then I also got a surgeon's preference card from St. Vincent, and it also did not show up very good on my laptop. But on here, they've got, these are just like the basic supplies, a basic ortho pack, a 10 blade, the drapes. They used Ioban, a U-drape, a stockinette, a lower extremity drape, a reverse fold drape, a split film drape, the drains, they use an evacuator drain kit and a hemovac. The dressings, zero form, non-adherent dressings, extra large wound vac, and the other stuff that they use is like a basin set, a needle magnet, a septo, normal saline, culture tubes. So that's that. And then these are pictures of the back table that I took pictures of also, that I got to observe. So the first picture on the bottom left is an extra Mayo stand that she used to have extra room to put her supplies on. The big thing wrapped in gauze that is sitting on top of everything is what they put underneath the patient's knee to help hold the leg up for the amputation. In the square case is a bunch of different sizes of osteotomes that could be used. There's also extra gauze, towels, and extra saw handles. The next picture shows that she has culture tubes, laps, and a septo, retractors, curettes, basic orthopedic set. Let's see, an oscillating saw, the listed knife and ties. And then the other two pictures are just a different angle that I got of the back table. So you guys can look at that later. And then sutures. Hold on one second. Okay, so the tibial vessels and peroneal nerve are identified, ligated, and divided using a 2-0 silk ties. And then the muscle flap is brought over the ends of the bones and sutured to the deep fascia and periosteum on the anterior side using a 3-0 ethelon. The skin flaps are brought together and secured using a 3-0 ethelon. And then skin is closed using either a 3-0 monocryl or 2-0 vicryl. And then those are pictures of all of those. Okay, pharmaceuticals. There are anticonvulsants like carbamazepine or gabapentin, and then there's antidepressants such as amitriptyline or nortriptyline, and these medications work directly on the nerves in your legs. Opioids such as codeine and morphine. And then the anesthesia is usually general, or they can do an epidural block or spinal. And then position is supine. And then, like in the picture that I showed you before, she had that thing wrapped in gauze. That's usually a triangular leg rest. And then they use the pneumatic tourniquet to position that over the upper leg to help block the flow of blood when they go to cut it. Okay, skin prep. Chloroprep is commonly used. The skin may not be performed. The skin prep may not be performed on the part of the leg to be amputated due to sepsis. The rest of the leg is prepped from the incision site up to the groin fold. And then draping. The section that will be removed can be isolated by covering and wrapping it with a Mayo stand cover and taping it in place, or using a sterile adhesive drape. Then you would perform a standard extremity draping technique using the impervious stockinette, 3/4 sheets, or split sheet and extremity drape. And if the entire leg is to be prepped and sepsis is present, follow the aseptic rule of clean to dirty. Begin at the cleanest, non-infected area and work towards the dirtiest part of the leg. And also, another Mayo stand cover can be put around the section of the leg to be amputated and used for handing off to the circulating person to transport that to pathology. Okay, so incisions. So the first picture is showing the shape of a mouth of a fish incision, which is what I said I was going to talk about later. So this is the incision that they will actually make. It looks like a fish mouth. And the second picture is showing an anterior, lateral and posterior incision. This is the same incision that they use on the amputation that I got to observe and is also the most common. So those are those. Okay, now I'm going to start the actual procedural steps. So just bear with me because I went into a lot of detail with these. Okay, so the first step is the surgeon determines exactly where to cut the tibia based on the available soft tissue for closure. The diameter of the leg is measured at the level of the bone cut. The flap length is equal to that diameter plus 1 centimeter. The distal end of the flap is determined and marked out. The anterior portion of the incision is marked out where the tibia will be cut and carried down to the level of the flexion crease. The lateral and medial incisions are drawn. If there is no infection or tumor, extenuate the leg before putting the tourniquet on. Okay. The incision should be made, number 3. The incision should be made in a decisive fashion to provide a clean and pure incision. When the incision is extended across the tibial crest, the surgeon deepens the incision to make a mark on the periosteum to serve as a landmark. And for this, the CST should have at least 4 or 5 fresh blades ready in case their blade gets dull, because they always need a clean, fresh blade. So, number 4, the incision is carried through the deep fascia, but the surgeon is careful not to separate the skin and deep fascia from the underlying muscle. 5, in the anterior portion of the incision, the surgeon must identify the saphenous vein and the saphenous nerve. The CST needs to have plenty of hemostats ready to pass, because at this point they are going to be clamping off a lot of vessels and nerves. So number 6, the lateral fascia is divided in the interval between the lateral compartment muscles and the gastrocnemius muscle. In the lateral compartment, the course of the superficial peroneal nerve changes dramatically from proximal to distal. Approximately, it is found between the peroneus longus and peroneus brevis muscles. And distally, it can pierce the fascia and change from the lateral to the anterior compartment. The nerve must be identified. Sometimes dividing the nerve distally better allows the surgeon to draw the nerve down transect it, and allow the proximal end of the nerve to retract well away from areas of pressure and scar that occur at the incision line. Okay, number 7. The lateral edge of the tibia is dissected free with a periosteal elevator. A curved clamp is placed down the lateral edge of the tibia and across the syndesmic membrane. Number 8. The fibula is felt with the tip of the clamp, and the clamp is passed out above the fibula. The muscles in the anterior and lateral compartment, as well as the anterior tibial vessels and the deep peroneal nerve, are all divided cleanly. At the bottom of the anterior compartment, the surgeon identifies the anterior tibial vessels